I'm just letting some other people in. And if you don't mind, Laura is recording this so that other people might like to, who might like to see it, are, and I hope that's all right with you all. Please let us know if it isn't in the chat. Right, I'm going to share my screen. Can I just check so I can see you, Laura? If you could keep an eye on the real hand or virtual hands for me, that'd be really helpful. And also, will you let me know whether you can see that screen?
Yeah, no problem. We
Brilliant.
can see, well, I can see that screen.
Yep, so can I.
That's great. Okay. Oh. So, so I am the Learning Disability Lead for the Northumberland patch, and please feel free to email me if you have any questions. I'm usually pretty responsive at that. So I'm going to talk through something developed by Leeds and York Partnership, and I've just blatantly stolen it from them. They have a 10 steps to annual health check success. So I'm just going to talk you through what they have decided is a really good priorities, and I agree with them. So learning disability annual reviews are a whole practice thing. How we approach our patients, how we speak to them, how we think about them, how we arrange their appointments is absolutely a whole practice thing, and it starts from that thinking about appointment setting when you're thinking about your annual health check. And for me, it starts then with our dedicated administrator, Deb, who then talks to the families, talks to the carers, thinks about how that appointment can be done best. Now, in our practice, we've already had a look at a questionnaire that the patients and family carers or carers have filled in with them, and we've made a decision about how we're going to do that. You know, does the bloods need doing before we see them? Actually, would it be better for the whole thing to be done in a one-stop shop? How long can that person tolerate in the practice? How long can the carer manage, and what day is the carer's best day to do this? That all feeds into that positive experience for everybody. And I think it's really, really key that everybody from first contact on the phone to the actual face-to-face review is engaged in that learning disability reasonable adjusted approach, which I'll come to talk on a little bit more. I've put in a couple of links. I've tried to put links throughout, so when you get the slides, you'll be able to have a look at them and just click on things. Some of our adults are not brought to appointments. They're too frail, they're too ill, they don't have capacity to bring themselves. And we need to support those patients because they're potentially the most vulnerable of our patients in this group. So there's a load of work on there. One of the things we have to do as practices is have a register of all of our patients with a learning disability. And there's some really good data on how to have a look at that and check that your register is about right. Now, we should have around 2% of our populations with a learning disability. Now, I have a really big contingent of learning disability patients because we have a supported living environment on our patch. So we have about 100 patients, but that's still nowhere near the 2%. And we know that the right people are not always on our lists. So there are people with a mild or moderate learning disability out there who are not on our lists of patients. And there's a number of reasons for that. One, we don't recognise them. In fact, I met someone yesterday that I thought, oh, do you know, I've missed that person's got a learning disability. He can't read, he can't write, he can't manage appointments on his own. He has social care to bring him because he can't bring himself. And I really just thought, oh, you know, I've really just not thought about this person. I thought he's had a mental health problem and didn't do very well at school. He has drug use. But actually, underneath all that, it's probably a learning disability. And we don't have a diagnostic service in this country, really, for people with a learning disability to get that label. However, we do have a couple of inclusion tools, we call them. So ways of looking at a patient with a bit of objectivity and thinking about whether they might have a learning disability or if they have a high likelihood of having a learning disability. And I've put the links in the chat. What you can do is use those inclusion tools, and what they will do is they'll tell you when someone perhaps can learn but has had poor schooling. They've got dyslexia, they might have a hearing problem. I've got a couple of those patients that I've done this with, and it will tell you whether they have a high likelihood of having a learning disability. And because we are very inclusive on our list of patients with a learning disability, those people can be included on your register. So don't feel that you have to validate that with anyone. Don't feel that you have to do anything else, but if as any sort of clinical person in the team you think, oh, do you know, this person might have a learning disability, please highlight them to your clinicians and get them to have a look at the chances. Now, having a learning disability label on a primary care record, having a label on a register, doesn't mean that you have automatic ability to get benefits for that, or social care involvement, or the learning disability team, but it does allow you to do an annual health check, get priority for flu and COVID vaccinations, get the right sort of literacy information sent out. Remember that the average reading age in this country, and particularly in North East North Cumbria, is 8. So sending easy read to patients who probably have a learning disability is much more appropriate. And the other thing is then you can think about the needs of that person in a different way. Think about reasonable adjustments, think about what they might need to access our service or services much better. There are lots of accessible invitations out there. I've included one, but they're really, really good, because actually what you need is something that you can use for patients with low literacy, where you know that when you send an invite letter, there's a really high chance that they'll be able to read it, or someone that cares for them will be able to read it, because we know that English is sometimes not a first language. We know that patients with a learning disability may be cared for by other patients with a learning disability or difficulties learning. So we do need to think about how we access our patients. Now, our DEB rings people generally if we've got the right phone number, but sometimes you will need to back that up with a letter, and we do also send out a questionnaire, which I mentioned. The other thing to remember is that all of the patients with a learning disability on your practice list will be sent reasonably adjusted screening information. So we know straight away that they've got information that hopefully should be at the very least more accessible for patients. If you are really struggling with a patient with invitations with how to engage them in a learning disability annual health check, do consider support from the learning disability team. They may well be able to help. It's really important that patients get a learning disability annual health check to try and prevent long-term conditions, to manage long-term conditions better, and to potentially spot early cancers. I've talked a bit about reasonable adjustments. I hope that those of you on the call know what they are. I've got a picture of them, but what's really important is that our patients and our carers know about them. Reasonable adjustments are simple things that we do in the practice. For example, making a bespoke appointment around that person's carer, or making sure that that person can come in on a day where they're not at placement. For example, giving longer appointments using Easy Read. But actually, lots of patients and carers don't know about reasonable adjustments, and we've developed a campaign regionally to improve that understanding. Now you can see the picture of the lady. Very soon you're going to be having pictures yourself of these posters, and there's a QR code and you can go on and actually read a little bit more about it in plain English. So we are going to be putting out those posters in your practices soon, and if you're really struggling with making reasonable adjustments for your patients' appointments, please do seek help from the learning disability team or myself. We've already talked a little bit about carers, family carers, paid carers. They're all absolutely crucial for patients with a learning disability. Some of our patients won't have anybody that cares for them or even looks in on them, perhaps patients with a mild learning disability. But carers and families can really help patients support their own decisions about health and bring them to appointments and follow on those appointments with whatever is necessary. So have a look at the reasonable adjustments. Think about how you promote annual health checks to your learning disability patients in your practices. Think about the posters that are out there. Think about how you think about your carers. Do they get a care review? Do you think about the carers when you're making appointments? And I suppose the other thing to think about is actually that carer. How are they? For a lot of our patients with a learning disability who are living at home, you might have an elderly carer that is just about managing. So it's really important to think about that, and also think about those carers who are looking after children with a learning disability. And remember, from age 14, they can have an annual health check, but that doesn't mean that before that you can't try and engage the families. So you'll all be using a slightly different template for your learning disability health checks. And for some of you, you'll be doing some of the checks, some of you will be picking up the clinical bits, some of you will be doing all of it. And I think one of the things we're working on as a region is actually having just one template that we all use now. I think lots of you will use Ardens. I can't see any hands, but Ardens is a decent one. And we are working nationally to think about what that template should look like. Alison. Or it might be Anne. I can see a couple of hands.
Yeah, we use that in Seaton Park.
Sorry, I can't quite hear you.
We use the Ardens template in Seaton Park.
That's really good. Alison? Is that a legacy hand, maybe? Okay.
I think it's Anne Madison.
Anne?
Maybe
I think maybe Anne's
from
said
before.
something.
Sorry,
Okay,
I'll lower
that's
it.
fine.
Thanks.
No, don't worry. Thank you. So the template's really important, and then we know that the bits of the template that each of you fill out they're all really crucial. So I can't do the bit, the clinical bit for patients unless the things like the blood tests have been done, the observations, and we know that patients don't always like that stuff. So making reasonable adjustments around them is really, really key. Making sure that if we definitely need bloods, that we are managing with EMLA and we are lying the patients down and we are thinking about distracting them. All those reasonable adjustments that are really important for this group. So each bit of this work is really, really important, and it all contributes to a patient's improved health. Think about a blood pressure and how we monitor blood pressure. Think about high blood pressure as a really huge risk for cardiovascular disease, stroke, dementia, heart disease. So getting the blood pressure right, getting a really good blood pressure that doesn't need to be repeated several times is really, really key. We've talked a bit about the sort of preamble to the check. Here we are at the check now. I again think it's really important to have a consistent approach across the practices. We in our practice have 3 of us that do the actual physical health check, and we talk about how we do that and sort of benchmark each other. So if there are other people either in your PCN or your practices that are doing these checks, it's worth just checking in with them and seeing what they do and share and think about best practice. I'd really like you to ask about reasonable adjustments actually at the appointment. There is going to be a national reasonable adjustment flag that was going to be appearing in our notes very soon, and we will need to be feeding in the information about what reasonable adjustments our patients need into that document. And obviously I will send out more information and perhaps do another one of these when it comes out. The slot for the doctor might not be to do very much. It might be just to think about some specific illnesses or issues that have been going on. For instance, a new symptom or a vague symptom that might be a cancer. But it also is to think about what routine checks, what testicle or breast checks, or checking someone's chest. So it's really important that a face-to-face is always arranged in whatever setting is important for that person. So for example, we've got someone who doesn't like to come to the doctors at all, so we go out to him. I think the other bit of things that we can do is be really hot on giving advice about proactive care. So we can see that that patient is perhaps overweight for their height, they've got a little bit of high blood pressure, they are smoking, and we really need to be spending time and concentrate on how we manage the sort of we call it a lifestyle medicine, I guess, but manage those risk factors or those risk behaviours that can impact on healthcare long term. So we want to be preventing people from getting overweight for their height and prevent them getting diabetes, because once someone with a learning disability has diabetes, it can be very hard to manage. We try and do the long-term condition management or the reviews in that appointment. So for example, if they have asthma or if they have COPD or diabetes, we do try and manage that all in that one appointment. Now that's a bit of a challenge, but it means that it's better for the patient and it's often better for the carer. 3 appointments as opposed to 1. We don't want to put more carer stress on. The other thing that often we need to do is an epilepsy review. We know epilepsy is a very common coexisting problem with learning disability. So we do medication reviews, we think about what targeted screening might be needed, for example, DEXA scanning, and we think about memory and mental health. We know that patients with a disability are prone to having memory problems from age 50 and younger if you have Down syndrome. The other thing I like to do is a carer review, think about that carer. What else do they need? Actually, are they coping? And giving them the strategies and also the information to get further support if needed. The other bit of the annual health check is a health action plan. Now, I remember when these came in about 10 years ago, 15 years ago, maybe. Nobody told me what to do. Nobody told me what they were. What they are is a distillation, I guess, a summary of what's gone on in the annual health check, what needs to be done in that next year. And for a lot of my patients, it will be, actually, we need to help you to lose weight. And it will be, I have referred you to the health trainer. It might be, actually, you want to have a smear this year, and this is what we're going to do to achieve that. I'm going to refer you to see the clinic in one spec, the colposcopy clinic. Now, one of the things that we don't really do very well is make that easy read. We have easy read health action plans, which are at the end of the review, and you can just print them off. But what I try and do is write in what I've said to the patient in plain English, as plain English as I can. It would be lovely if we could just maybe translate it into easy read, and I'm sure there's an AI solution to that. However, I'm not that techie, so I don't do that. I just write it in plain English and make sure I discuss with the patient and the carer, or just the patient if there hasn't got anyone else with them. But then at least they have a written record, and I know the professional carers really like them. The other thing to think about at this point is that health and care passports are really, excuse me, one of the ways in which we communicate reasonable adjustment needs or needs at appointment in hospitals. And I think patients and carers often have these, and it's a time to think about updating them. And there's also information you can give out about what to do when you're going into hospital to settle things down in terms of your nerves or concerns. I think I'm keen in the future to think about quality checking. We really focus on the numbers of annual health checks, and we have to get 75%, soon to be 85% of our checks done of our patients. Now, you will all have a group of patients that you really struggle to get in. Now, some of them will be not brought, but some of them will have capacity to make decisions and will have decided they don't want to come in. But I have, if you would like, I've got questionnaires that you can hand out to your patients and carers about how good the service was. And I think there is government information about how you can quality check yourself. So I just wanted to think about a couple of questions that come up frequently. As a group, are there any other questions that you have about this work? Anything else, any sort of, I don't know, hot questions that you really struggle with? No hands, but if you think of anything, just shout. So the first one that I get regularly is, how do you refer to the learning disability team? Well, I have now in your systems is a form. So if you would like to use a populatable, a free pre-populating with all of the patient details form for the learning disability team, that is there now in your systems. And something will be coming out in the bulletin about how to use them. So there's just an email inbox, so that's really, really easy. The next one is, how do we engage patients who don't want to come in for a check? Now, for me, that is all about what I said at the beginning about getting that bespoke appointment, that really early check-in with the family, with the patient about what makes it easier for them, think about reasonable adjustments, but also checking in with the teams, for example, the learning disability team, if you're really, really struggling. What resources are there to support us in the practice? I've put this question in because before I had a TeamNet page. Now, if you want to look at the sort of resources we have for learning disability, if you look on TeamNet under clinical support, there is a learning disability oblong, which we call lozenge, and in there is quite a lot of guidance. It's not as comprehensive as my topic page, and I am working on that. But if you have specific questions and you're not sure that you can find it on there, please just shout, email me, and I'll sort it out. So who can support our patients with a specific problem? For example, I have a man who's diabetic, who we're really struggling with his diabetic control, and it's partly to do with his learning disability. So I would at that point refer into the learning disability team. They will assess the situation and decide on who the best person to take that particular problem forward. So the other big thing is around consent and capacity to make decisions about medical treatments. For example, I have a patient who has a really awful hip problem, but he also has diabetes, and we had to have a good capacity discussion about whether he had capacity to make the decision not to have surgery, and we needed a multidisciplinary team, including the family and the patient, to do that. So there are teams to help you. They are, so for example, the learning disability team will have to assess whether they actually can see that patient or help, but social care is also a good option. So we talked a little bit about blood tests earlier, about making reasonable adjustments. The other thing to think about is desensitization. So for patients who are very scared of coming to the surgery, obviously you can think about home visits, you can think about district nursing, but actually reasonable adjustments, one of them is desensitization, coming into the practice to see what it looks like, see what it might feel like to be sitting in the chair, see what it feels like to look at a needle. You know, there are ways around that, and again, the learning disability team can help that. So one of the other specific questions I get is, how do we support patients with obesity or cancer or a mental health problem? All of our services should be reasonably adjusted, i.e. they should be accessible for patients with a learning disability. However, for lots of these things like the diabetes, the National Diabetes Prevention Programme, it's very prescriptive, it's like a script. So actually they are not organised around people with a learning disability or someone who cares for them, really. So while we're working on that, I appreciate that it is very difficult, especially if we're trying to prevent diabetes and prevent obesity. But again, think about reasonable adjustments, think about all of the services like the mental health services. Talking Matters Northumberland, now called NHS Talking Therapies, Northumberland has got a reasonable adjustments pathway, and it also supports autistic people. For people with cancer, you'll see that I've put down the passport to my health and well-being. There is actually a passport that you can use to help patients organise their thoughts around appointments and who's involved and any thoughts they have. So I think that's a really helpful resource as well. Are there any questions? I've obviously whizzed through all of that because there's a lot to cover in a very short time. Okay. If there are no questions, you can always come back to me on email. I'm going to just share something else now. This is around, see if I can find it first. So can you see that now?
Yes.
Oh, brilliant. I can hear Laura's in the room, so I can actually hear. Right, okay, so this is something that I wanted to talk to you about around the kinds of illnesses that people with a learning disability are more prone to and how we can make that better as a team. Every year, reviews of patients with a learning disability and now autistic people who have died are done, and we look at the national and we look at the local themes about what's happened and how we can do something about it. So that's called LEADER, and you'll know LEADER from sometimes having to notify LEADER that someone in your practice has died who has a learning disability and now autistic people. So from the last report, which is in 2022, we have 5 leading causes of death. Now, in the past, congenital malformations and chromosomal abnormalities was not top of the list. It was respiratory problems. So actually that's, that we'll come on to talk about that a little bit more. Second is cancers. Then we've got influenza and pneumonia. And then we've got cerebral palsy, which is a type of movement disorder, not always associated with learning disability, but it can affect your respiratory problems. And then we've got heart disease. So it's actually quite a big change from before. So I mentioned respiratory problems, so exacerbation COPD, aspiration pneumonia were very, very common last time. And the other thing that was common last time was COVID. But last time also on the list was epilepsy, which seems to have come off the top 5, which is good, but also it may well be number 6, I'm not sure. So I just wanted to briefly talk about COVID. I mean, I think we're all sick of talking about COVID, but what I think I wanted to highlight was the difficulties that our learning disability patients had in that time. So people with a learning disability were more susceptible to COVID. They couldn't always recognise the signs and symptoms. They didn't understand the rules, and they couldn't also follow them without significant support. And some of them may have been medically exempt from mask wearing. Care and support was also at a bare minimum at that time, and vaccinations sometimes are more difficult to administer or consent for in terms of capacity and needle phobia. Now, all of that means that patients were 6 times more likely to die of COVID than patients without a learning disability. So it was a really horrific situation. And you'll remember that it took us a long time to convince the national teams that learning disability needed to be part of the original early vaccination schedule. So it really was a tragedy of enormous proportions in our learning disability populations. And if you think also that quite a lot of our patients live in a shared living or some sort of supported housing, that the risk of infection spreading quickly, like in the care homes, really was very upsetting. So I wanted to talk a little bit about the things that cause the deaths. One of the things we don't know about lots of our patients is what is their genetics going on. So we know lots of our patients with Down syndrome, lots of our patients who have Marfan syndrome. There's a couple of others that are a bit more common. But for lots of patients, they have a learning disability. We don't really know why. And a proportion of them, probably about 25% plus of people with a moderate learning disability or more severe, and about 10% of patients with a mild learning disability have got a genetic disorder, and we don't really know what this is. We have started to do genetic studies in children, but for lots of our adults, so pretty much all of our 18s, certainly most of our over 25s will not have had any sort of genetic studies done. And certainly patients that I've approached to think about that so we can understand their condition a bit better have declined. So the other thing about cardiovascular disease is the big effect of smoking, alcohol, substance misuse, hypertension. So the prevention and diagnosis of heart disease is really, really important, and hugely we need to think about diabetes. Now we know that QRISK 3 is now going to come into our systems going forward, but it's really important that we focus on the lifestyle factors such as smoking, particularly to try and reduce the risk of heart disease, stroke, dementia in the future. Smoking is the one single thing that if you cease, it actually makes a huge, huge difference to your health. So if you're going to spend time with your patients around some prevention work, some proactive management, allowing them the space to talk about how they're going to stop smoking and referring them onto the smoking cessation service, letting them know that this person has a learning disability will really, really help. So we know that people with a learning disability often live in the most deprived areas of our country. So that's one of the ways we can do to think about reducing inequality for these patients, is to really assertively think about how we can support their lifestyle choices. The healthier, the better. Aspiration pneumonia is a really, really common problem at the end of life. And in our learning disabled patients, they're a bit more prone to it. They often have undiagnosed chest disease, for example, smokers and COPD, things to do with their genetics. And we need to think about those people who get recurrent chest infection because they may well be having problems with their swallowing, dysphagia. They might well be having an underlying chest disease that we haven't managed to diagnose. For example, they can't tolerate dyspirometry. And I think it's really important that we think about preventing recurrent chest infection in terms of prophylaxis, so antibiotics, thinking about how we manage problems of swallowing, and thinking about PEG feeding for people. And again, we know that smoking cessation support is really important. One of the things we don't do well is recognise when patients are getting worse. Recognition of sepsis, recognition of frailty and multimorbidity are all really, they're a lot harder in people with a learning disability. And our current frailty scores that come up, you know, the severe frailty, moderate frailty, they overestimate frailty in a person with a learning disability. So what that means is it says severe frailty, but they may well not be severely frail technically. I think alignment of disability care homes to particular practices, that's been a really important way to help manage. And MDT working with staff with skills will help us manage that posture and swallowing bit, thinking about dietitian support, aids and nursing needs, and is that person in the right setting? example, they might be in supported living, but actually now they need to be in nursing care. And it's really important to think about the recognition of long-term conditions such as diabetes. Remember that a DNA CPR is only used if appropriate, and you mustn't use learning disability or Down syndrome as a reason for it, just like you shouldn't write that on a death certificate. Cancer, it's really difficult, particularly with vague symptoms of cancer. What we don't know is whether the patient with a learning disability will recognise those, and we don't know whether they'll be then able to act on them. And when it's vague, it sometimes is easy to miss. I think the pre-assessment questionnaires are helpful here in that it might alert you to bleeding where you wouldn't have expected, or weight loss. But I think it's really important to think about your targeted questions and investigation at your annual health check. And there is some really good details out there, really good leaflets and support. Macmillan are really good around vague symptoms and cancer red flag symptoms. So there's the Be Cancer Aware work, and there's also the Be Screening Aware to support screening, because if we can support screening in our patients, then we're much more likely to get things at an early stage before it's become symptomatic. And I know that there are issues getting people, for example, cervical screening, and I hope that going forward we will have a better way or a more sustainable way of doing HPV screening for patients. For example, I think there's a pilot going on around a urine sample. So that will be really helpful. But if we can get better at screening, then obviously we'll need to be less targeted around the red flag and vague symptoms, because we've already picked it up. But they're both really important, I think, and I would really encourage you to have a look at both of those websites because they're fabulous. The other thing is, when a patient comes in with a learning disability, you might just need to gather all their symptoms and pop them in the Mind Maps website, which you can just tick off the symptoms and it will tell you what cancer investigations to do. So it also supports multiple investigations and referrals if needed. For example, a person I've seen recently needed to have both a GI and a hematology, and she ended up with a hematology cancer, and she also ended up with an endometrial cancer, which we found on the CT scan for her GI. So obviously she didn't have a learning disability, and it was actually very unlucky. But what you don't want to do is find those two cancers one after the other rather than together. And it's really important that if you're referring someone for a cancer investigation, that you also think about referring them to the learning disability team. They can make sure that that appointment for review and then any of the investigations that are needed for example, an endoscopy, are done with the utmost of reasonable adjustments to make sure it's done once and it's done properly and it's completed. We see time and time again patients with a learning disability turning up to an appointment. Nobody knew they had a learning disability. The appointment was a disaster. They then didn't want to have investigations. They then turned up for an investigation appointment that was a disaster. And then it just goes on and on and on. So if we can get it right first time, that would be really helpful. And the learning disability teams, both in the hospital and the community, will really help you with that. Epilepsy. Epilepsy and learning disability often coexist, and it's really often really poorly managed epilepsy, or very, very intractable epilepsy that we really struggle to manage. We also know that patients with a learning disability are more at risk of SUDEP because of perhaps not taking their medication regularly, perhaps not understanding the risks. So I've put in some information about SUDEP, sudden death in epilepsy, to think about with your patients. The other thing is for epileptic patients is their medication side effects and the effects such as drowsiness. And it's really important to think about your vitamin D in these patients. Patients with a learning disability tend to be outside less, they tend to be out in the sun less, and they experience vitamin D reduction in their bloodstream because of the anti-epileptics. I would suggest an early referral when you're having management problems, and consideration from advice from the neurologist. There is a specialised neurology service in Newcastle for learning disabled patients. The other thing for families and carers is how to give buccal midazolam, and we're working on that regionally because I think it's very difficult, the buccal midazolam, to abort seizures. So some families will already have advice and prescriptions for that from their neurology team. So sepsis. I've already discussed how it's actually quite difficult to manage and quite difficult to recognise, but one of the useful bits about the health check is having data such as pulse, blood pressure, oxygen saturations, so that we can actually have some sort of normal. and we can think about what behaviours might emerge, often behaviours of distress when patients are not very well. And families are really good at recognising when things are not quite right for whatever reason. And I think health and care passports to smooth the transition into hospital are also really, really important to make sure that patients with a learning disability are not just dismissed as it's their learning disability causing the problem, or they've got a new mental health problem. Diagnostic overshadowing is a really, really important concept in patients with a mental health disorder and a learning disability. Often it's just a learning disability. But actually, if a behaviour of a child or someone with a dementia is unusual or distressed or distressing, then we don't think, oh, it's just their dementia. We think about what's underlying it. We wouldn't ever think a child was screaming in distress and not think about why. So we need to think about why these behaviours of distress emerge. And this is a leaflet which I hope you'll have seen before. It's an early warning tool basically for families and carers, and there's a number of them. The other one is Restore 2 Mini that care homes sometimes use. Just thinking about the types of things that might need addressing by a healthcare professional. So, for example, not having a poo for 3 days. One of the most distressing things I've heard again this year, and we keep hearing it, is that patients with learning disability die of constipation. And one of the problems is we know that patients are more prone to this, so we could do something about it. We could be more organised around it. Patients with a learning disability often don't like particular foods. They might have a reduced fibre. One of my patients just eats quiche, not even vegetable quiche, just quiche, which is obviously not very great for your bowels. It's very common for patients with a learning disability to have reduced fluid intake, especially when they're not very well. And we use medications such as antidepressants or antipsychotics that make people prone to constipation. So it's really important that patients, carers, families know about Stop and Watch, or there's some new constipation resources from the NHS Learning Disability team around what constipation looks like and what to do. And I think lots of our patients in our practice have got a proactive laxative plan, especially when there are medications which are known to cause constipation, for example, opiates. And it's really important to think about how the families might use them to prevent people dying of impacted poo. And also, when we're thinking about our patient, we need to think about, actually, do they need those antipsychotics? Do they need those medications? Are they on antidepressants that they now don't need? So we need to think about that. And our patients have all got a patient plan, an alert on their notes, and a code to say their risk of constipation. So proactivity, I think, is the key there. I've already mentioned about learning disability teams for referrals. It's really important that the patients get the right support to have the appointment in as an appropriate way as possible. So what can we all do in practice to help patients live well and not die too young? And bear in mind that patients, although they die 20 years too young, what that means is that lots of our patients die in their early 60s. As a general rule in Northumberland, our patients are dying in their late 70s and early 80s without a learning disability. So they're missing 20 years of their life here. So in addition to the annual health check, think about the support of patients who cannot find our services for whatever reason. So they might not be able to reach them physically, they might not be able to reach them because they don't know about them or don't understand, or there might be poverty issues. They need our proactive support to get into the surgery. Think about the hospital passports or the health and care passports that we use to smooth out attendances. Think about reasonable adjustments. Think really actively about the family and carer and listen to them about what's going on. And I also use any appointment as an opportunistic chance to review health. Strongly encourage screening and early identification of long-term conditions with blood tests, for example, people at risk of diabetes, and have a look at the reasonable adjustments and the reasonable adjustment campaign work that I've enclosed to make sure that patients get the best chance of understanding how best to make an appointment. The other things to think about is think about annual health checks for your 14 pluses. How are you making that happen? Are you thinking of your patients at age 13 and putting them on the list, making sure they get called at 14? Are there people in your practice that are children that you think, oh, they haven't got a label of learning disability, but they might need one? Do you need to talk to someone about that? Think about your dedicated admin staff to send the questionnaires and arrange appointments. Get to know those families and carers over time and make sure that when those reasonable adjustments are arranged, think about how they work. Did it work well? Did you need to tweak anything? Did you need to change it for next time? Make sure you're using the codes or practice alerts to make sure that everybody knows about them, and think about the reasonable adjustment campaign and how to show it to the rest of your staff so that everybody understands. Get to know why appointment is not attended, and think about coding adult not brought to appointment if there's no capacity or capability to bring themselves. And it's fine for nurses to do lots of the check, but they always should be a dedicated either nurse practitioner or a GP for checking the medical bits. Liaise with the learning disability teams, and I know our link worker Amy from the learning disability team has been into most of your practices to talk to you about your patients, and make sure that going forward, if you have any questions, they can answer your queries, or so can I. And remember the health action plan to be sent to the patient, the carer and any staff. I think that's the last slide. Oh, there's the reasonable adjustments, the top 10. But don't feel limited by them. If there's other reasonable adjustments you need to make, please do make them. It's about making that patient feel calm and listened to. Right, thank you. So I'm going to stop sharing. So I don't know why, but I've been very breathless throughout that presentation. I'm going to have to go and sort myself out. Any questions? You've all gone very quiet. Lynn, you look like you've got a very nice cup of tea there.
Absolutely, I've had a busy day so far.
Nice to have a bit of a break.
Yeah.
So anything anyone wants to ask?
Just to say, Kathy, I'm sure you can pop the slides into the chat.
Oh.
Is that all right?
Can I?
Or I can forward them on if you want.
Yeah, I'll just,
Yeah.
Is that okay? Yeah.
Absolutely, yeah. If you want to forward them on to me, and then I'll make sure that everyone who has attended today can get a copy of those.
Yeah.
And if anyone has any questions going forward, please feel free to contact me and I can liaise with Kathy on your behalf.
You've all gone very quiet. I'm assuming that that's plenty. So, yeah, lovely to see you all. Thanks, Catherine. You know where I am.
Thank you very much,
Okay,
Kathy.
no worries.
Thanks so much. Thank
Bye.
you. Bye-bye.
Thank you.